Thank you. Before we move on to the mission statement, I would like to take a moment here, a moment of silence. Everybody knows of what happened recently down in Texas, and I'd like to take a moment of silence and reflection for the families of the children and the staff in that horrific event. Thank you. Next, we will go to Donna for the reading of the mission statement.
Macomb County Community Mental Health, guided by the values, strengths, and informed choices of the people we serve, provides quality services which promote recovery, community participation, self-sufficiency, and independence.
Thank you. Next item is adoption of the agenda. I had Sandy print out an amended agenda that is in front of you. We added item 7H a little bit earlier today. I apologize for the lateness of that, but something we want to get Bruce moving on. So it said, let's add it on, and it was pretty simple. So I'll take a motion to approve the amended agenda.
So moved. Support.
Motion from Megan, support from Selena. Questions, comments? All right, all in favor signify by saying aye.
Aye.
Aye. All opposed? Agenda is adopted. Next, we will move on to item 4, hearing of the public. Anybody from the public wish to speak? You have 5 minutes. Give us your name. Anything on the agenda? Anybody from the crowd? Nobody's moving. All right, we will close the first hearing of the public. There's another one before the end of the meeting, and we'll move on to item 5, approval of the minutes of the CMH full board meeting on April 27th, 2022. Take a motion to approve those minutes.
Support.
Motion from Donna, support from Lori. Questions on the minutes? Seeing none, all in favor signify by saying aye. Aye. All opposed? Minutes are approved. Item 6, approval of the program and budget meeting minutes. We did not have program and budget, so there are no minutes. And we will move on to item 7, request to approve. Item A, request for approval to contract with Jefferson Wells to complete the Medicaid verification audit. I'll take a motion to approve.
Move to approve. Linda. Support.
Motion from Linda, support from Megan. This is an item Dave and I have had a discussion on, and items like this. We're going to revamp the process a little bit. We've started to, come to the board for approval for RFPs, and now they have somebody, so now they're going to start the conversation to talk about a contract, and then they're going to come to us again for a contract. I think that middle step is a little erroneous. Dave and I have talked about that, so we will still see the RFP, and we will still see the final contract. I'm just trying to cut out a step in between. Dave, go ahead.
Thank you for that. So we did the RFP, and Jefferson Wells is our previous vendor in this area. So they were scored as being the best recipient. So we're just asking for the board's approval to move forward with them into the contracting process, and then that document will come back to the board for approval.
Questions on that? Okay. All in favor signify by saying aye. Aye. All opposed? Motion passes. Next is item B, request to approve the Mdhhs Amendment, Community Mental Health Services Program 2022. This item was approved by legal. Take a motion to approve. Motion from Selena.
Support.
Support from Brian. That is also Dave.
As you can see, they did some amendments specific to self-determination and the fiscal intermediary guidelines. I am on a 6-month statewide work group specific to that topic. The state issued 2 updated documents, and we're reviewing how that comports with our contractual guidelines and stuff. So there'll be additional updates on that to follow. PASSAR is the nursing home screening process that we do. It's a pre-admission screening annual resident review. Some of the reporting requirements were updated. I don't have the specific details in front of me, but if there's questions about it, I'm happy to dig up that research and forward it. But it's just an amendment to our current CMH contract.
Questions for Dave? Okay, seeing none, all in favor signify by saying aye. Aye. All opposed? Motion passes. Next is item C, request to approve draft recruitment and retention plan for Macomb County Community Mental Health.
So moved.
Motion from Megan, support from Lori. Dave?
This board has heard numerous times now from our providers that the staffing crisis is causing a lot of impact to our service delivery system. We are looking at our rates, and I'll cover those a little bit more, give an update, and the CFO report will touch on some of that as well. But the missing piece was the recruitment portion to really allow our providers to compete in this market. So, and also in keeping with some of our neighboring counties and regions have been able to do, and you've heard that comment from our providers as well. So it's our hope that this plan, once approved, will give our providers additional support, much needed support, to help them recruit staff, get them in the front door. There's a referral bonus in there too, so that existing staff can, if they recommend somebody who ends up being hired, they'll benefit financially from that. And then all staff on their annual date too. So again, it's intended to keep people in place, help support our system while we continue to navigate the staffing crisis.
Donna?
Two questions. I'm assuming this doesn't include direct staff, and the second question is there a estimate of the cost?
Good question. No, it does not include any of our staff internally. Thankfully, the timing of this is good, though. The county put out that they're giving all county staff, Tracy, help me if I misspeak, but a 2% actually on the 28th of this month. So at the time that the county staff are getting pay increases, this allows us to help our provider side as well. As far as total estimated cost, it's an estimate. It's very difficult. It's impossible for us to identify all of the exact number of the impacted staff. Richard, I don't know if you want to. Richard and I had this conversation. Our best guess is looking, again, some of our neighboring counties and regions have implemented this, and we're aware of their financial impact. We do have sufficient funds under contracted services to provide this, and we'll be able to track and report it in detail as it's rolled out. But yeah, we do have a comfortable buffer in addition to the rate changes that we put in place. So we're assuming, I won't even do a guesstimate at this point.
No guesses, Richard?
Given our size compared to some of the regions around us, I would say a rough estimate would be for all providers, and that would include SUD and non-SUD providers.
Thanks, Donna. Nick?
Yeah, you've listed this as a draft. What additional steps are necessary?
Approval.
Oh, so upon our approval, you're putting this into effect. Thank you.
Anyone else? Okay, all in favor signify by saying aye.
Aye.
Aye. All opposed? Motion passes. It is no longer a draft. Next, we will move on to item D, request to approve residential lease A. Take a motion to approve.
So moved. Support.
Motion from Donna, support from Selena. Tracy, TJ, Tracy. Either or, both. Can you kick the microphone on too?
TJ can
Perfect.
speak about the specific details in case you have questions, but you will notice a pattern that this lease is a shorter term. So we really aren't renewing the majority of our leases, or we're at least exploring all our options when it is necessary, or doing them for 18 months to 2 years.
And this is the first in a long series that will be coming before you in the coming months, where our landlords, just like everybody else, is looking for additional funds. We're fighting tooth and nail to keep that in check. But this particular home, there was no outstanding issues with the landlord, and the provider was more than happy to make the repairs as well. So there's nothing on this home that I would see that would prevent. I recommend this lease.
Thank you. Questions? Nick?
David, we were talking about going to a different system. Is that moving along, or is that the reason for the shorter leases?
Those conversations continue. I met with the folks at the Provider Alliance, and we've started this conversation, and we've sent them correspondence that we would be in support of the agency who holds the license to that facility actually being on the lease agreement rather than us. Of course, we're in the middle of a pandemic, and they're concerned about those issues. But we're having good conversations. This is why we're not doing the longer-term leases.
Okay.
We would prefer not to be to hold as many leases as we have historically going forward. So yes, this will be it's a longer-term process. The pandemic has definitely impacted our plans. And I heard clearly from our providers about some of the issues related to assuming a lease right now, even if the folks currently living there, the cost of care, is more than sufficient to cover the lease arrangements. Because of the pandemic, there's other factors that are causing them to, the staffing as an example, they're putting additional financial resources into their staff right now. So entering into another agreement is not on top of their list right now. But they're hearing us clearly, and we'll continue to, yes, work
So
on
you're
this
moving in
model.
the direction we were talking. Yeah, I just see the leases going up rapidly. They were going down for a while, now they're going up pretty rapidly.
Yeah.
So looking at alternative ways is a good thing, and shortening the lease gives you that flexibility if you can work something out. So that's good. Okay.
One caveat that I would also mention is that we, in the past year, we have closed close to a dozen homes, and that has severely impacted the amount of beds that we have. That does translate to hospitalization costs as well. I step outside my wheelhouse there, but I do know, and I've been told many times, that that's a direct correlation in cost. So we're doing everything we can to keep the lease costs down, at the same time notify providers that this is a limited endeavor, that we are going to lease the homes continually forever. So we have a couple of things in place to try to carry that water message forward.
And with every single one, TJ explores, hey, are you interested in doing the lease? Like, it's a continuous conversation and going, we're only doing this as a Band-Aid, and this will eventually be the outcome.
Thank you. Anyone else? All right. Seeing and hearing none. All in favor signify by saying aye.
Aye.
Aye. All opposed? Motion passes. Want to mention that one was approved by legal also. Item E, request to approve 43740 gross spec leases. These were also approved by legal. Take a motion to approve.
Move to approve, Ryan.
Motion from Ryan, support from Selena. Tracy? You guys scattered after the last one. I was confused.
This is for our north location on Grossbeck. You will see in the explanation 3 different paragraphs because they are interdependent on each other. You have the north location. It's a 5-year lease. If you notice, it is at the same rate that it was previously in the previous lease to that. It was a little battle even to keep it at the rate. We know that there's lots of commercial opportunities, but what TJ and I did is, even though we did not get the lease price to go down, the cost to reestablish a location outweighed the benefit. And just, we've been there for a number of years and that. The second explanation, if you notice, both in the main lease and in the next one, which is the MyCare lease, they mention each other, right? Because it permits us to sublease. So just as a reminder, MyCare is our healthcare or our health provider at the location in North. And they are a partner, and someone else could probably definitely describe better in my turn than me than exactly what they do for us. But you will see that they're staying in the same location at the same relationship, where there's not any exchange of money. The third one talks about Genoa. Genoa is a pharmacy, or it will be a pharmacy. They are paying the build out of the building, and again, collaboration with the North landlord. And you will see that the rate is like, forgive me, it's like 1506, 1507. So all we did is charge what our cost was, plus a small kind of administrative coverage, but they are also covering all of their utilities, data cost, janitorial, anything like that. There's no cost to us. Dr. Serpa and Jeff are here if you do want to learn a little bit more about the proposed partnership with the pharmacy.
Thank you. Questions on these 3? Linda, go ahead.
So having the pharmacy there means someone could be written a prescription and get it immediately filled, right on
Correct.
site. And so these 3 things really enhance our integrated
Yes.
care.
And they could best describe, I think, maybe having like the vision of this location. We already have integrated healthcare there, but it's kind of moving it to the next level.
Is that Dr. Serpa hiding out back there? We never get to see you. How are you? Come on up, you guys. Come on up to the microphone if you want to add anything.
Yes, sure. So this is a project that was started about maybe, I will say, end of last year. The vision that I had for our clinics was that we could be able to provide a comprehensive range of services. And the North Building, having the access to MyCare, was the perfect spot to be able to bring a clinic that could be able to support in providing care for our patients. I used to work in a different county, and I always value the quick access to a pharmacy right on site, because it will not only as a provider help me to maybe sometimes debrief with the pharmacist, but also patients appreciated the fact that they could just come in, get their prescription, and have a service right there and then. And if there was any confusion with the prescription or anything that needed to be corroborated, they will immediately have that resolved, on site. So it was my vision coming in as the next chief medical officer to be able to provide a comprehensive array of services as well. I think patients find it very helpful, and I think it helps us also to promote education as far as compliance with medication, creating that, that just array of services that patients in some way or another could benefit from. Now, as you guys know, last year we also brought in, thanks to our partnership with Genoa, the medication coordinator pilot. And that was bring pharmaceutical staff from Genoa into our clinics to be able to help our nurses into providing better education for our patients, increase their compliance, specifically trying to work with that population that is on injectables, who tends to be very challenging to treat. And, most of those patients end up in injections because of their lack of insight. So as we had them coming on board, and that pilot proved to be very helpful for our staff and for patients, the idea of developing this pharmacy started to become something more real. and something that, eventually we could definitely have. So we started to have those conversations with the leadership. I was supported by Dave, by Adam, in moving forward with the idea. And we had a long-standing partnership with Genoa, and I think that it could, only make it stronger, but at the same time, looking into the future, my vision is that we hopefully will get to the point that each of our locations will have, access to their own pharmacy. And Genoa thinks it's possible, but we got to start somewhere, and that's the reason why North, in its capacity to offer more of a comprehensive array of services, including, we're going to have their MAT program coming up. We're going to have as well, the support of My Care and their intervention. So I think it was a really good starting place for us to kind of test this and be able to grow it to our next other branches, other clinics. And Jeff was,
So the MyCare patients, if they're prescribed a blood pressure drug, they can get that filled there too.
They could,
The
yeah.
pharmacist will know interactions and all of that. That's great.
And Jeff, if you have anything to add, yes.
Lori, turn your microphone on.
So is it just for people that are in the North Center now, but it could be that if there's somebody that receives services from CMH, could also go in and get their prescriptions filled?
Technically,
That
they
might be
could
using
too.
CVS right now?
Exactly. Somebody who decides, who have been going to CVS and now they know, well, my CVS was 3 miles away.
Or
And here
back-ordered,
is,
right.
We are obviously spread the news with our providers to say, hey, we have this site, here in this location. If your patients want to take advantage of it, they're free to come in. So it's just not North patients going there. It's pretty much everybody. But obviously, the North patients who are already attending the clinic see it as a great benefit because they
Absolutely.
get all their services there.
Okay, thank you.
So if I may add, I just want to enforce the fact that for the people we serve, having that pharmacy at the same location that they receive their other services, primary care, mental health care, would be just huge, especially when it comes to medication adherence. If they're already there for face-to-face service, a lot of times in the past, they would get a prescription, it'd be electronically sent to their pharmacy. They might never go pick it up. At least if it's right there in a building and the case manager can even walk them down to the pharmacy. Hey, remember, we got the pharmacy here, come get your medicine. Those type of services are going to be beneficial to the individual served. Again, for therapists and case managers, pharmacists could assist with answering questions about medications that are outside their scope of practice, especially when a nurse or a psychiatrist is not immediately available. And speaking as a nurse myself, a vast majority of my time working was spent with communicating with pharmacies or, transporting medications. So being able to walk up to that pharmacy window to obtain that whenever there's a med change would be excellent for the nurses at that location. Additionally, the CMC, the Community Medication Coordinator from Genoa, if the pharmacy is there in that building, she would be able to allot a majority of her time at her other direct locations. So it wouldn't necessarily be, her there at that pharmacy. She could be supporting the nurses and the consumers served at the other locations, West, ACT, East, etc.
Perfect, thank you. Any other questions for them? No? All right.
Can you just set the expectations of when this will happen? So if you notice, they all say October 1st, all these leases, but we'll actually contact Genoa as soon as the contract is signed, and they will start their build out. So you will start seeing changes. They estimated about 6 months. We're hoping less because we're giving them about 4.5 months to make it up and running by hopefully October 1st.
Great, thank you. Anyone? All right, thank you, guys. We have a motion and support to approve. All in favor signify by saying aye. Aye. All opposed? Motion passes. Next, we move on to item 7F, request for approval to provide a rate increase to contracted community living supports and respite providers. Motion from Lori, support from Selena. Dave?
Again, you've heard from our provider network thanking us for the rate increases to this point, but saying it wasn't sufficient. The caregivers, the direct support professionals who are using the community living support code and the respite code, that's, everybody is saying you can go down, work at the McDonald's, wherever for, $15, $18 an hour. It is having a serious impact on their ability to keep staff. They were reporting to me that they were having staff leave in the middle of a shift because they got called to another job that was paying them more money. It was critical. So what we're proposing is moving our community living support standard unit rate to $5 a unit, which is a 15-minute unit, and our respite code to the 484, I think is what's in the packet. That's really what it's taking now. I've been in statewide meetings where other CMHs are reporting, that they were posting jobs at $15 an hour and nobody was even responding to the ads. So it's our sincere hope that with this unit rate increase, with the recruitment and retention plan, again, working with the Provider Alliance, that we'll be able to do a countywide media blast that, you can now get a bonus. 44. You can now get a hiring bonus. You can get a referral bonus, and they can start them, advertise it at a higher starting rate as well. So, again, this is listening to our providers, doing the market comparison to our counterparts statewide, and we feel strongly this is what's needed to help everybody as much as possible right now. I do not pretend this will fix everything, but it will help alleviate some of the issues that our providers are dealing with right now, and that our families and people in our community are dealing with when they're trying to identify supports to keep them in the community.
Thanks, Dave. Ryan?
Thank you, Phil. Dave, what was the basis for the $5 going up to $5 and then $4.84? Why those amounts and not, say, another amount?
Again, we looked at the comparisons to other regions, heard from our providers. They were able to share with us detail, those providers that crossed county boundaries and things. And again, some of them gave us detailed feedback about, we posted a job at $15 an hour, crickets. We posted it at $17 an hour. We got 100 applicants, and we were able to then actually hire, and it was really small numbers, like 2 or 3 people out of that, large number. So we're, again, hopeful that with the hiring bonus, when that's formalized, that they'll be able, and they can advertise this at a higher starting rate now. And for people that might be considering, this will keep them in position going forward. So we looked at all those factors when we were coming up with that, the $5 an hour unit rate.
Thank you, Dave. As a follow-up, I work with some employers that have, and Megan will know this probably more than me, but try to get that starting rate as high as possible. And it's kind of a funny thing when you go to a store, you see that first number really matters. And so I guess for the $5 one, that makes a lot of sense because it has a 2 in front of it. But for the other one, I think it's $19.36. So I'm wondering if there's just a little bit more to squeeze. If we could bump that up to $20 an hour, is that going to help us with the respite care workers? And I don't want to put you on the spot right here.
Well, historically, it's a difference in the service codes.
Okay.
So they are very similar. According to the Medicaid manual, if I'm providing community living supports to fill, there's a specific reason that I'm doing that. There's a specific goal that I'm working with him to try to meet. Respite does not have any of those. It's purely, I'm there to kind of monitor somebody's health and safety, and it's minimal. So the documentation, the expectations are less on the respite side, and we're just trying to keep that distinction going through the rate system as well. I know it's close. Those were kind of our historic numbers that we had to build on, and we just bumped them up.
Okay, I know I don't know what the cost is for this, and I know but, I mean, I wouldn't be opposed. I mean, I'd have to go to the full board, obviously, but bumping it up even a little more, like 5.25 to make it to that 20, if the juice was worth the squeeze. But this is a tremendous increase right now, and if the data shows this, then the data shows it. What is the cost for this? Is there any cost for us at all, or?
The annualized cost when we looked at this, we did compare it, right, Richard, to prior year utilization?
Yeah, I was thinking
3 to 5 million? Okay.
325, yeah.
25?
No, 325.
325, okay. Thank you. No.
No further questions? No further questions. Thanks, Ryan. And this is full board, so this is final approval today. Any other questions, comments for Dave? I just want to make a quick note. Back when I started, we were cutting things like respite, and it was absolutely miserable. So to be 180 degrees from that about 5 years later feels so much better. So thank you for doing this, team. Any other questions, comments? All right, all in favor signify by saying aye.
Aye.
Aye. All opposed? Motion passes. Next is item 7G, request to approve the updated MCCMH Board Committee list for 2022-2023 with one change. I left Donna off the Policy and Legislative Affairs Committee, and she would like to continue to serve on that committee, so I would like approval with that change. Motion from Brian. Support from Megan. Questions, comments? Anybody going to throw tomatoes at me for the list I put together? I've got shields. All right. All in favor signify by saying aye. Aye. Opposed? Motion passes. Next is 7H. It's the new item from Bruce, request to approve attendance at out-of-state conference, clubhouse staff, and member. Take a motion to approve. Motion from Nick, support from Donna. Bruce?
Yeah.
Last minute, Bruce, go ahead. I'm just kidding.
Thank you,
Go
Mr.
ahead.
Chairman. I appreciate it. I think, obviously, most of you know that I'm constantly looking for ways to improve Clubhouse. Right now, we've had a number of conversations with improving some of the equipment there at Clubhouse, getting more tech savvy, because we believe that people participating in Clubhouse virtually is not going to end anytime soon, if ever at all. And it's the same with staff improvements. One of the things that we do on an annual basis is we respond to the Michigan Department of Health and Human Services for any grant opportunities that we have for either accreditation, reaccreditation, staff training. Last year during the pandemic, we were awarded a significant amount of money for training, and it was done virtually. There's no substitute for in-person training, especially in a Clubhouse model. There's just no substitute for that. You really need to be on site at a training base to feel what it's like to be in a Clubhouse, to smell what it's like to be in a Clubhouse, to understand what it feels like to work side by side with the population that we serve. And we're in an opportunity right now where we're able to go out of state for colleague training. We have $7,000 that was awarded to Crossroads Clubhouse for colleague training this year. The first opportunity for us to go is in August. That is for a 2-week training. There'll be one administrator, Diana Ray, that has volunteered to go. I will be her backup in the event that she's not able to go, even though I hope she can go. I've been to colleague training 3 times now, so I'd really like to see somebody else go and get that opportunity to learn all the nuts and bolts of what Clubhouse is and what it isn't. There'll be a staff member, Lance Fisher. He'll also be going, and there'll be 1 Clubhouse member that will go. The beauty about going to 2-week training is the fact that they must come back with an action plan. And the challenge is to look at Crossroads Clubhouse critically and really try to value what it is that we do and what we try to do and what we embrace. So that action plan is intended to come back for us to put in place to improve Crossroads Clubhouse and to make it more adherent to the 37 Clubhouse International Standards. So it's just a great opportunity. With the $5,000 or with the $7,000 grant that we got from the state of Michigan from the department, our cost really is just going to be for travel there and back, food expenses, and overnight stay for the travel down and the travel back. So I suspect, if I were to guesstimate, probably going to be about $3,000 out of our operating budget for staff to go down. And we have 30 days to submit all of our receipts to the state of Michigan, and they'll reimburse $5,000. We'll be doing the same thing in September for another staff person, Christy Saylor, who will go down for colleague training as well. But hers is more specialized in looking at either improving the work order day or improving our transitional employment program or education program, our housing program, whatever the case may be. So it'll be more specialized in September when she goes.
Thanks, Bruce. Any questions? Nick, go ahead.
Yeah, I don't have a question, I just have one comment. That as many of you know, I'm also on the board of directors of the Mental Health Association of Michigan, and I'm on their nominating committee, and we've been looking for new board members, and we were interviewing one who's had dealings with clubhouses all around the state, and Crossroads came up as an example of the right way to do it as we were moving back into in-person from the problems that the pandemic had. So I just want to congratulate Bruce on the great job he's doing there.
Thank you, Nick. Appreciate that. Thank you.
Thanks, Nick. Anyone else? Okay. All in favor signify by saying aye. Aye. All opposed? Motion passes. Thank you, Bruce.
Thank you. Have a
Keep up the
night.
good work. Next is receive and file of an item that we just approved. Receive and file the updated MCCMH board committee list for 2022-2023.
Support.
Motion from Linda, support from Megan, and Sandy will be sending out a copy to everyone. All in favor signify by saying aye. Aye. All opposed? Received and filed. Item 9, resolutions. We have no resolutions. Item 10, voucher listings. I'll take a motion to pay the bills.
Motion to pay the bill.
Support.
Motion from Ryan, support from Linda. Questions, comments? Seeing none, all in favor signify by saying aye. Aye. All opposed? Bills are paid. Next is management report, and we will start with Richard.
Good evening. For our March finance report in the packet, a few highlights for the board this evening. Page 2, our revenue and our eligibility continue to stay pretty stable from month to month. Just a quick update on the federal emergency. We were anticipating, or I think as I mentioned last month, the federal emergency was extended through July 15th. At this point in time, the expectation is that the federal government is going to give the state a 60-day notice before they're going to terminate, so that would have been May 15th. We've not received a notice at this point in time, so the expectation is that we'll get another 90-day extension now to October 15th. So we're now looking at a federal emergency that likely will not end until October 15th, and there's already rumblings, although nothing official, about it going another 90 days until the beginning of 2023. So that being said, we do anticipate eligibility is going to stay high through at least the end of this fiscal year. And just as a reminder, some of the provider rate increases that we did provide, the 8.62% and the 10%, are tied to 6 months after the end of that. So as we build our budget now for next year, we're planning on at least 6 months of that increase into that. The other thing that we're hearing from the state of Michigan, just while we're on that topic, is all CMHs throughout the state, including Macomb County, is being asked to make sure that the contact information for persons served is updated in our systems, because the state will start reaching out and trying to get them to reapply for Medicaid eligibility as soon as that federal emergency ends. So obviously that's a priority for us from that perspective. If we look at page 3, the big highlights are the same ones that we've talked about pretty much every month. Cash and investments is significantly up, primarily because of the additional revenue we're getting through those eligibles that we have every month. And then the amount that we anticipate potentially having to return to the state is up as well. So we're keeping our eye on that every month. The other highlight that I have is on page 5. Medicaid through the month of March has a surplus of about $36.7 million. Healthy Michigan, $7.2 million. And State General Fund about $1.6 million. So if we talk about that Medicaid and Healthy Michigan surplus, 36 plus 7 is about 43. And then we start talking about some of the programs that we've approved tonight, like the retention payments, estimating around 10 million, right? So we're taking that 40, trying to cut it down a little bit by that 10 million. The increase to the CLS rates, right? 3 to 5 million. And just a little bit of a context for that range. 3 million is what we see the utilization kind of right now at by that rate increase. We do hope that rate increase, as more staff are coming on board, we're actually going to see utilization go up as well, right? So it's not just the rate increase, but the utilization would go up, so it could be as much as 5 million in that increase. Again, some of that will come out of this 40 million surplus. So again, trying to be very intentional on what we're using that money for and how we can best support the system in the process. So those are our big highlights through the month of March. Obviously, we'll keep our eyes on that month over month, and if there's anything else that pops up, whether it's at the federal or the state level, we'll keep the board informed.
Thanks, Richard. Questions?
I think it's,
Linda, go ahead.
I think it's at the back of your report, so I assume it's you. The top 10 providers and contractors, I'm looking at the SUV one, and I don't see one that had a lot of grants and stuff, and we do a lot of business with them. I don't see CARE on there. They're not one of the top 10?
What we do, the way that we pull this information is this is specific to our treatment providers, so it's anyone that gets a claims payment on our treatment through the Focus system. So it's possible that if they're getting a lot of grant dollars, that wouldn't fall onto this graph specifically. So that could be a reason why they wouldn't show up. So this is specifically related to claims payments for SUD treatment services. I do know they are a large provider for us, and I could definitely take that back to Helen and request some information, but I believe that would be why. Yep.
Thanks, Linda. Anyone else?
Phil?
Ryan, go ahead.
Richard, is there any, I know we, I don't know if forfeit's the right word, but if we have excess money in our account, we send it back to the state, I think is the way it works. I mean, how are we going to look by September 30th of this year?
Well, there's a lot of different moving parts. So that 43 million that we talked about, again, we're hoping to spend 15-ish of that. The other moving part is the state is talking about a rate adjustment that just happened here in May. And so that we're actually going to get more revenue than we have been for the first few months of the year. So I would say that number could be $25–30 million that may go unspent by the end of the year. And again, A lot of the reason for that continues to be a lot more eligibles than were anticipated, so a lot more revenue than we anticipated. And we want to be very careful not to create programs that may be unsustainable. So we're trying to balance that, like making sure that we're taking very intentional small steps in the right direction, but important steps in the right direction on how to use the funding. So I'm going to say 25 to 30 would be probably a conservative estimate at this point.
And does it affect our next year's funding if we have unspent?
It does not, luckily. So about 4 to 5 years ago, the state moved to a morbidity-based rate-setting model, and so they look at the diagnosis and the utilization within our county. There's a little bit of penetration rate and all of that, which I know Nick has mentioned in the past. But in general, the primary driver is they look at the person served and the needs of the person served. So I don't expect that to penalize us negatively going forward. We do have a rate-setting meeting with the state end of June, beginning of July, and so I'll have a better, like, for sure, yes or no to that question, a yes or no answer to that question in a couple of months.
Okay. And final question, is there any, and this may be more for Dave, anything that we can use that money on, maybe that doesn't create long-term costs that we're, just jumping ahead before September 30th. I know we're thinking of it.
We're trying. At every, yeah. We've done a lot, and we continue to spread the word. So
okay, well, thank you both, and it's a good problem to have. Like what Phil said before, I'd rather have that problem than the cutting problem. So
yep.
All right, thank you, Richard.
Thanks, Ryan. Donna?
You may not know the answer to this, but I'll throw it out there anyway.
Sure.
When we have the $25 to $30 million that goes back to the state, does that money stay in mental health services at the state, or do you know then what happens to that $25 to $30 million? Because we may not be the only county that has excess. And I'm wondering, where does that money go? Does it stay in mental health services, or does it just go into some other services?
Yeah, so that's a great question. So it's complicated, surprise, surprise. Because most of it is federal, what the state does is for every dollar we give back to them, they have to take the federal portion out of that and send that back to the feds. So for Healthy Michigan, that's about 90 cents of every dollar has to go back to the feds, and the state actually keeps 10 cents. So a very small amount of that. For the traditional Medicaid program, the federal portion of that is about 65%. So for every dollar we send back, 65 cents would go back to the federal government, and the state would keep about 35 cents. The reality is anything that goes back to the state has to go through the whole appropriations process. If it's state money, it would go through the whole appropriations process over again. So it could be redistributed depending on the appropriation process at the state level. So there's no guarantee that it will or won't end up back in mental health. It could, but it's not like earmarked for that purpose.
Thanks, Donna. Nick?
Yeah, because so much of this additional has been one-time money, that's kind of confusing things. But also the needs are more than one-time needs. So we've been trying to figure out how to do that. Has there been any discussion on increasing the percents that are allowed for risk reserves and savings, or is that all federal law?
I would say that there has been discussion about it, yes. So actually, Dave and I were in a conversation with a couple of state representatives, and we said, realistically, with the state of this, having an increased carryover or an increased, whether it's ISF or savings amount, really makes a lot of sense, because not only do we expect, the need to continue past, right, it potentially will, as people become more interested in engaging in services, right, and become more involved in the community, we might actually see an increase in the cost and the utilization. And so it really does make sense. I would say most of the feedback I've heard from the state is, well, that's interesting, we should think about that, but not really any kind of commitment of making a change, unfortunately.
Is it state law or federal law that controls?
It's actually state contract currently that requires the 7.5% limit. So there is an ability at the state level to make that change. I'm not sure. We've had the conversation a couple of times, Dave, I think.
And the contracts are the contracts that we kind of always approve, but have nothing to say about, are primarily negotiated between our state association and the department. So is the state association raising that, or maybe we should be urging the state association to raise that? Because it just seems to me that rather than lapsing the money, when we know we're going to need money, when the extra federal money disappears, to reserve it and spread it out so that it's doing good over a longer period of time would make a lot of sense.
It does make a lot of sense. I know, so the association does negotiate our general fund contract, which of course is the smaller amount. There is a group of PIHP directors that negotiate the PIHP contract, which is where the ISF and the savings limitation is. The tricky part is there still are some PIHPs out there that are not lapsing money as we are. So there are a couple of them still in the state that are struggling financially. And the other side of the coin is we can raise the 7.5% limit on what we can keep, but the state is likely going to say, well, then we want to raise the 7.5% limit of your risk on the other side if you're overspending. And there may be some PIHPs that would be hesitant to want to raise their risk because of historical financial issues. So I think there's a lot of competing things in that space that would have to be figured out before.
But it's on the table.
We've brought it up as a suggestion, as something we should be considered, and it just, I don't know, I don't feel that there's been an appetite to really move down that path by the state, our state partners at this point.
They both said it was interesting, but that's as far as they went.
So, but we're trying to be creative for you, Nick, I promise.
Thanks, Nick. Anyone else? Ryan, go ahead.
I don't want to take up any more of your time, Richard. Nick, that's a great idea. I think we wish we could do that. If we do have extra money, is there anything, you mentioned other CMHs that are struggling. Is there anything that prohibits us from helping those other CMHs out?
Yeah, so for our state general fund dollars, the 1.6 million surplus that we're showing in the financials, we are allowed to offer that up to those that might be struggling in their state general fund. Our Medicaid contract does prohibit the ability to move that money around. So the option is you use it or you give it back to the state. There isn't look at your neighbors and share, unfortunately.
Thank you.
Yep.
Thanks, Ryan. And we've done that previously. Yeah. Linda, go ahead.
The general fund dollars have way less restrictive in terms of what we can do with them. So that is an area where we can be really creative, and there's got to be need. And it's not a huge amount. It's a lot of money to give back to somebody, but.
Yeah. I do know Dave and I are meeting, not just Dave and I, but Dave, and myself, and Adam, and the rest of the team are meeting almost weekly to talk about what are the different ways that we can really maximize the utilization of these funds. So, yeah.
So this might be the time to, like last year we did smaller things, refrigerators or whatever, you need a generator or something. This might be the time for something big, one-time big thing that. I was with a former state rep on Monday night, and he was just appalled that we gave money back. I don't tell that to everybody, but he found it out. And we don't want to do that again, but it looks like we're headed in the same direction.
So we have a program in place that was started by the state, encouraged by the state, and we continue to do it for provider stability payments. So anything that impacted them, COVID related, that impacted their ability to operate, we're able to consider those requests and use our funds in that way. And we do a monthly report, and the state just said continue to track that and then make it available upon request. Last fiscal year, it was a monthly report that we sent directly to the department. So we continue that. The programs and special projects, again, at every opportunity, we're encouraging providers to be creative. What could you do, and submit those requests to us. The board committee meeting that we had to look at some of those and approve those took a little longer because we had to go through and get contracts in place for some of those. But we have completed those and we're getting that money out hopefully by the end of this fiscal year. So I apologize. We've been working hard in this area. I owe you all a summary update about our activities in that area. So I'll work with Richard and Christina, and I'll get you that level of detail. But yeah, we've done a lot of work and helped a lot of people, and some of it's new contracting, and I'll touch on some of that in my report as well.
Thank you.
Thanks, Linda. Thanks, Dave. Anyone else? I just want to thank the team for going after this. I know we talk about this all the time, especially, starting last year. It's just a different problem to have. You go from negative money to too much money. I don't know. It's weird. But, thank you for hearing the board and trying to come up with ways to spend that money so we don't have to give it back or to a different county, as nice as that is. But any other questions, comments? All right. Thank you, Richard.
Thank you.
Dave, you're next.
Phil started our meeting with the moment of silence, which was very appropriate. Thank you. We did reach out to the Macomb Intermediate School District and our other school contacts to offer our support and assistance in any way. I did receive a thank you, and they'll let us know. It's just, it's unfortunate we have to keep offering that out there. There are activities going on at the state level. Dr. Serpa, I know you went to the Behavioral Threat Management Assessment training. Is that the one sponsored by the Michigan State Police or an association?
No, we're doing it with Wayne.
With Wayne County, and so we are working with Wayne in Oakland, and Dr. Serpa did attend that training. Again, it's behavioral threat assessment specific to schools. So we continue to try to help. We're trying to get ahead of this and be as proactive as possible instead of trying to be reactive after something horrible has happened. It will take time. There is, on March 21st, when the state reorganized, they created a children's department for the first time ever. And there's a lot of money in the budget specific to schools and mental health services. So we'll see how that shakes out and how best to partner with our schools. I did meet recently with Justin, who's the superintendent for special education for Macomb Intermediate School Districts. We do have shared contracts and things with the schools, and we're looking to, definitely expand on those to help meet the needs. Everything I read is the mental health concerns for children specifically are increasing. So we're being collaborative and working with our regional partners and with our local schools. We also have a health management associates are completing our community needs assessment. So I approved the language, and we'll be emailing out that information within our provider system. So some of you might see that information coming out. And some of it, I think there will be a board level component as well. So heads up on that. Last Saturday, again, our regional efforts, there was a Tri-County Veterans event. It was held in Pontiac. Very, very well attended. I went. Diana Lasky is our vet navigator. So she did a presentation. There was a lot of display tables, a lot of display tables with a lot of really good information for veterans and their families. I was able to meet the statewide coordinator for the Vet Navigator system and learned a lot about the history. It's only Michigan and Texas are the two states with this program. He had nothing but the glowing comments to say, nice things about Diana, which of course I echo. It's a really good program, and Macomb is definitely up there with our veteran population, the size. And our Vet Navigator can help veterans, anybody who served for an hour, for any length of time, and their families. So it's a really good program. So yeah, it was a nice day. It was rainy on Saturday, but it was at United Wholesale Man. It's a big sports complex in Pontiac that I had never been to before. But yeah, it was well attended and well run. I mentioned Diana. It's Carrie Sutton is our peer support in our Vet Navigator program, and they were both there. And yeah, proud of both of them. Speaking of our integrated healthcare at our north site, I also had a meeting with the state of Michigan. The MyCare, as an FQHC, our federally qualified health center, all of them in Michigan use electronic health record called Azara. So the state is working on, they got some grant dollars to work with PCE, which is our electronic health record vendor, to have those two systems talk to each other. When you get that data flow between the physical health care and the behavioral health care, some really good things can happen. It makes identifying issues easier. It makes the sharing of information about medication compliance better. When we look at programs like complex case management, which will be part of our NCQA process, this is definitely a really good thing. So the state brought it up last year, and they said they were working with, I think, Shiawassee and Saginaw and another part of Michigan. I said, can I get in on that too? And I spoke to John Villacerta, and then John left the state. So then it came up at another state meeting, and I spoke up again. So I made contact with Lindsay, who's over that program now, and she said, which was good news for us, John, before he left, put in a good plug for Macomb County, and we're getting some grant dollars starting next fiscal year that will cover the cost of the Azara subscription. So it's $50,000 to $80,000, and we're going to be part of that project starting next fiscal year. We're evaluating if it's worthwhile to start earlier, but given that we're pretty much into June right now, October's not too far away. So stay tuned with that, but we'll be working with all of our FQHCs to get that communication better between those two systems. I did meet with our Provider Alliance again. Good group of people. They're very clear with their struggles and the thanks when we're able to help. So thank you to the board for approving the action items on today's board meeting. Those were a lot of those were very much in response to the issues that were brought up by that group. The rate increases, again, we're trying to help our providers. We're trying to, spend our money appropriately. So we are looking at, the providers are telling us the longer term fixes are easier for them. These short-term fixes are hard to navigate and implement, and really don't impact their systems, internally as much as possible. So we're working on getting the message out that we are planning to continue the board approved 8.62% increase into next fiscal year. That does hinge on the public health emergency. And on that note too, the state has started to communicate that that will end at some point. And when it does, it's going to be, before it does, it's going to be very important that anybody who is Medicaid eligible does have all of that paperwork into the state before they lose those benefits. So we are working within our system. The state has asked that the contact information for everybody who's Medicaid eligible be as current as possible so that they can blast this information out. So we are working on that. But we're looking at those increases being in effect probably minimally until April 15th of next year, along with the 10% increase we did for our residential licensed providers. Then the CLS and Respite increases that were approved today. We do have still to bring forward to you next month the evaluation and management codes, which are for the psychiatric services. We're looking at that. Again, our providers need to have good psychiatric coverage available to them, and sometimes they need to work with temp agencies, and those are rather expensive. We are continue to review its community living supports in a licensed setting and personal care in a licensed setting. The state, I'm on the statewide work group for tiered rates. So they're looking at how would they define a level of care and in the associated rate for those services, those daily services. But until then, because that's not going to be in effect for a while, we're trying to make sure that our system is appropriate and, again, responsive to our community needs as much as possible. So we continue to have those conversations as well. Then I just made notes on things I need to follow up on tomorrow when I get back in the office. So I'll leave it at that. Happy to answer any questions.
Megan?
I guess it's kind of a Richard Dave combo question, but to Linda's point about spending that money, which I know you guys this is like I completely understand. I'm just sitting here at a board meeting twice a month and have this random idea when you're talking. But is there any limit on how last minute we could spend that money? Sub-question. Is there when you talk to providers, has there been anybody who's been struggling to bring people back in person? Because I know when Bruce said that, I thought about that. I just feel like people need to be back in person 100 million %. Now safely, absolutely safely. So is there any way we could spend that money to make for barriers or something? I was trying to think like this. I mean, this probably costs money to put these up, but there's really no maintenance of it. I mean, I'm sure the janitorial staff sprays it down and wipes it off and that's it. It's not like if you put something like that in a place where a provider has individuals come in, it's going to be like an ongoing cost that they're not going to be able to keep up with. So I would just say my little one voice on the board is get everybody 100% back together with their community, so maybe that's just a question of, has anybody struggled to bring people back in person? And if so, with us using that money for barriers and things like that, could we even do that?
Yes, we have providers who are struggling to get people back.
But is it
primarily,
staff?
it's on our skill building side.
Okay.
And primarily, it's because the family or the individual does not yet feel safe in coming back into a group situation. We have a lot of personal protective equipment that we have offered up frequently, routinely to our provider system. We have a lot. So if anybody would like it, yeah, TJ and Tracy are both nodding. Our basement is full. If anybody would like N95 mask and gowns and shields and gloves, we got you covered. Really, the provider response to that has not been what we expected.
If they didn't want it,
yeah, they didn't express a need for that. A lot of them got it themselves directly through through other sources. We have testing kits. We are pretty well set.
In today's workforce update, you'll see that there's 5 events occurring, or 6 events occurring, I'm sorry, but we're distributing PPE, Narcan, and COVID tests, 500 of them. So
Oh,
see the
wow.
details
Yeah.
there.
That's awesome.
And we have lots more.
Yeah, so we're actively working to get that out. Yeah, and then the one-time cost, the cost to, adapt their sites, we happily covered that under stability payments.
Yeah.
So yeah, we've got that covered.
I just wonder if stuff like this would be, like I feel comfortable. I know that the numbers are rising, but I feel comfortable being, between you and Selena right now because we have this one thing. So maybe if people, maybe they haven't wanted the PPE because maybe people don't feel comfortable wearing a mask or they're worried about it. So maybe something like this, and I'm just pointing at these because they're on each side of me, but something where it makes people feel safe getting back. Maybe, just a thought.
TJ?
Megan, we have already built all of these.
I saw it, yeah.
At our sites. So
Uh-huh.
our direct sites, we have all of these. At our homes, in our residential sites, it's a little bit more difficult to do.
Sure.
But those direct care workers, they're wearing masks, they're wearing gowns, they're getting as close to people as, bathing and feeding. So they have all that equipment.
Okay.
And we've really tried to push that out as much as possible.
Okay. Thanks, Pete.
But at every provider meeting, my meetings with the Provider Alliance, I'm stressing to people, be creative. We do prefer the one-time cost,
Sure.
those fixed costs, because it's easier to manage and to review and approve. Like I said, I will get to each of you the summary of what we've been able to do this fiscal year through the stability payments, through those special projects, through our general fund exception request process. We've been able to do quite a bit. So, and then with these rate increases and stuff too, again, a huge focus is exactly what you guys are asking about. What are we doing to spend these dollars as best as possible to support the people of our county without it having to go back? That's my day, every day.
Yeah.
And we are making a big dent in that.
I know you guys are. I appreciate you. I know you guys are trying to think of all the things. Just a
We're
random idea.
we're trying, yeah, but I would never pretend that I could think of everything. Our providers have gotten very creative, and I'll be able to share some of those with you, so.
Thank you.
Anyone else with questions for Dave? Okay, thanks, Dave. Next is the UKG update from Tracy.
Just as a reminder, I think the board had asked once upon a time for an update about how we're doing with implementing our new human resource payroll system. That's what UKG is. And we did that along with our general ledger update, which under finance. So Tracy has taken on this project, which truly is an immense amount of work. So Tracy, thank you so much for...
Tracy, before you start, since we have a little presentation here, I'll take a motion to receive and file the presentation.
Support.
Linda and Megan. Tracy, go ahead.
Is it there? Yes, ma'am.
that. Tracy made this look pretty easy. Again, I can't stress the amount of time and effort that Tracy herself put into this. And her ability to explain it to others is like me. It's just so very much appreciated. Tracy and I are meeting tomorrow afternoon as well with Carlin Semlo, who's the new HR director at the county, just to say hi, how are you, and identify ourselves and congratulate her on her recent promotion to that position. But because of our size and complexity, we interact frequently with the HR department at the county. So kind of a kickoff meeting tomorrow afternoon as well. So again, Tracy's our point person on everything human resource related. So thank you so much, Tracy.
Thanks, Tracy. Thanks, Dave. All right, no questions, no comments? Linda, go ahead.
No, other agenda item.
Okay. We do have a motion to receive and file and support. All in favor, say aye. 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 All opposed? All right, received and filed. Couple reminders. Program and budget is currently scheduled for Wednesday, June 8th. I am tossing around the idea of possibly canceling it because there's a conference up in the North Country and slow drivers on this. I'm kidding. So I will assess how many agenda items we may or may not have, and then I will let you all know if we are going to have program and budget or not. We may just do what we did this month and just have full board, but I will let you know. Speaking of full board next month, it will be Wednesday, June 22nd here at 6 p.m., and there will be no appeals meeting tomorrow morning. It has been canceled. It will be rescheduled. Lori and Sandy will let us all know when that new date and time is. Linda? Tomorrow is canceled. You can sleep in, Linda. Linda, go ahead. You had something?
Yes. All of us know about the increase in anxiety and depression and substance use disorder and everything. And so just in my life of going around, I run into people who could use some information about CMH. And I was at the office a couple weeks ago and saw one of these cards that are at your desk. And I thought, because I can't remember that number, that CMH, and I always have to try to look it up. And then this also has the crisis line on it. So Sandy helped facilitate me getting you a supply of these to just have in your wallet to hand out and for you to be able to recall the telephone number and have it handy. So thank you, Sandy.
Thank you, Linda.
And I'm sure if you run out, they'll get you some more.
Thanks, Linda. Thank you, Sandy. Anyone else with anything else? Can someone explain this? Hold on. Dave can explain it.
Hi, Dave.
STEP is Services to Enhance Potential. They are one of our newer providers. Primarily in Wayne County, they do supports coordination, skill building, and supported employment. They're able now to, and have expanded to our county to help us meet those needs. And again, we are intentionally focused on increasing our supported employment services here in the county. So they are having an open house, and it's there on 23 Mile Road in New Baltimore. 2 sessions from 10 to 2 and earlier midday, and 1 in the evening from 4 to 7.
This is for anybody?
Mm-hmm. Yep.
Thanks, Lori. Thanks, Dave. Anybody else? Okay, we will move on to hearing of the public. Anybody from the public?
Good evening, everybody. My name is Sean McGregor. I'm with CEO, just to give our monthly report. For our Anchorville location, they went bowling, attended the flashback movies weekly at MJR, and they also worked on and completed their butterfly garden. Over at Clinton Township, a school toured 6 student/parent pairs around the center. As well, they will soon be attending Greenfield Village when it opens. And then at Mount Clemens, our Academy Center, they purchased 8 new outdoor games: cornhole, basketball, volleyball, yahtzee, etc. Over at Washington, they delivered over 240 Meals on Wheels. They utilized surrounding malls, MJRs, libraries, parks, nature centers, bowling, C.J. Barrymore's. And also at Washington, they will be hosting a traveling craft sale Friday, June 10th featuring Father's Day gifts. And then Lastly, with Washington as well, they had 7 new persons served, started to attend just this month. Our CEO summer camp is the week of June 20th through the 22nd at Brandenburg Park. During these days, there will be educational and learning themed crafts and activities. Finally, Thursday the 23rd will be ending with a Hawaiian themed picnic at the beach at Metro Park. We'd like to invite all board members who are interested. I'd like to see you there. And then on the back of my report as well is a mock and/or draft of basically an award the person served would be receiving for their achievements for the last previous 6 months. And then lastly, just CEO and myself would like to thank the board again for passing the proposal for meeting the needs of people with challenging behaviors in the community. So thank you, guys.
Thank you, Sean. Anyone else from the public? You're not public.
Can I just ask what time the picnic is?
Go ahead.
The picnic on the 23rd, what time is it?
I think they're still figuring that out, but if anything, it would be between 9 and 2.
Okay, we'll probably see you before that anyway. Thank you.
Thanks, Sean. Thanks, Megan. Anyone else? All right, seeing none, we'll close hearing of the public. I'll take a motion to adjourn. Motion from Nick, support from Lori. All in favor? Aye. Aye, we are adjourned. Everyone have a safe Memorial weekend.